My topic is on para-PSLD. As we know, we have foraminal stenosis in about 8 to 12% of our patients, causing significant radicular or claudication symptoms. This may be because of disc herniation, facetal osteophytes causing stenosis. Sometimes there can be cysts. A stable asthesis also can cause these radicular symptoms, and rarely you can have tumors. Approaching this foraminal stenosis with conventional technique requires bigger incisions, leading to more soft tissue trauma, poor visualization, and delayed recovery. And it is not justified to put screws in these cases, even though you have a robot. Coming to minimally invasive approaches, we can approach it with transforaminal approach, para-PSLD or para-UB. Transforaminal approach was it's a very good technique. However, it requires more radiation, technically more demanding, longer learning curve, and there is limited bony decompression, and there is risk of dysesthesia post-operatively because we are working very close to the root. UB requires 2 incisions, requires more radiation, and it is definitely more invasive. Coming to para-PSLD, you can do it under general anesthesia or regional anesthesia. We don't prefer local anesthesia. Positioning is standard the way you want. Instrument, we require only standard PSLD instruments. Coming to the marking, we take the AP view, we mark the midline and the lateral pedicle line. The incision is about 5 cm lateral to midline or 1 to 1.5 cm lateral to the lateral pedicle line. Then we dock the cannula, dilator and cannula over the isthmus or the pars. So that is the bony landmark. That is the cannula in position, and I will show a couple of cases how it is done. This is a patient who came with foot drop. He previously had a L4-5 decompression. Later he developed foot drop because of foraminal stenosis here. You can see the osteophytes there on the right side. This was done with the para-PSLD technique, and this is the decompression which was achieved. Okay, so you can see the exiting root fully decompressed after decompression. This is another case. This is the L5S1 level with the right L5 radiculopathy. You can see the foramen is completely blocked. Again, it was done with the para-PSLD, and here I will show a video. So we land on the isthmus. We should identify 3 bony points, that is superior articular process, the isthmus, and the transverse process. This is the place where we dock the cannula. Then we drill the tip of SAP with a diamond burr. So once we do the drilling, I cannot fast forward it. So once we do the drilling, we have to use a kerrison to do further bony decompression. Then we have to release the foraminal ligaments. Laterally we have the intertransverse membrane. So once we release this, we can identify the exiting root, and if required we can drill the transverse process and also the isthmus and part of the pedicles. So once we do this decompression, the root gets completely decompressed. The most important thing is the radicular vessels accompany the root, and if you injure it, it will cause torrential bleeding. So bleeding control has to be meticulous. So before we cut or pull anything, we have to be very sure that you are not cutting the vessel, because if you cut the vessel, it can cause tremendous bleeding. So here I am drilling the isthmus now. It is preferable to use diamond burr because the root is very close by, especially if you are operating for a disc, the root will be pushed up by the disc. So you can see the joint there. Now the tip is trimmed with the burr. Tip of SAP is trimmed. So we use Kerisons to remove the foraminal ligament as well as the intertransverse membrane. Once you identify the roots, then it becomes easy because you know where the root is. So till we identify the roots, you have to be careful. So you can see the root at the bottom. Once the root is identified, it becomes easy. You can see the root and you can fully decompress it. For lack of time, I will skip this. And that is a post-operative MRI scan. You can see the foramen is opened up, both in sagittal and axial sections. If you want to see a full surgery video, you can go to this link, and time is also mentioned. You can watch that. Complications are rare if you are careful. Sometimes there can be root injury, post-operative asphyxia, hematoma, bleeding, and if you are aggressive, you can end up with fracture. Take home message: it's a good alternative approach for a foraminal pathology. You have to be aware of complications such as bleeding, and it's a good alternative. However, I still say that transforaminal approach has its own indications. Thank you.